Everyone wants to learn how to manipulate, everyone wants to perform manipulations in the clinic, but there's a time and a place for manipulations, and more importantly, there's a time and a place to not perform manipulations. And so in this video, we're going to be covering an extremely important topic, and that is the absolute and relative contraindications to performing manipulations. Now, depending on your source, there may be some contraindications listed here that are not in your source, and vice versa, you may have some that are not listed here. Bottom line is there's a lot of overlap and a little bit of discrepancy between different lists. So in the end, use your brain, use logic, ask yourself, should I be manipulating on this patient? If the answer is no, don't do it. Let's begin by discussing the absolute contraindications. If the patient has even one of these, you would never use this technique, never manipulate anywhere on the patient's body. The first absolute contraindication is osteoporosis, which is decreased bone mineral density. We are using a high velocity thrust maneuver. So if the patient already has weakened bones and we're performing a high velocity thrust, it increases the likelihood they'll fracture in that site. And generally, osteoporosis doesn't just occur in one spot, it occurs all over the body. So if they have osteoporosis, it's absolutely contraindicated to manipulate. And on the topic of bones, also fracture and ankylosing spondylitis. That would be absolutely contraindicated to manipulate. Another absolute contraindication, which is a broad term, is instability. Now, manipulations are generally done for one of two reasons or both. Number one is pain reduction, and number two is increased range of motion. Now, people with instability, generally speaking, already have excessive range of motion, sometimes pathologic range of motion. And so not only would manipulations be unnecessary, they could also be very dangerous. Take, for example, somebody with rheumatoid arthritis or a connective tissue disease such as Ehlers-Danlos syndrome or Marfan syndrome. Oftentimes with these patients, we see weakness in the ligaments of the upper cervical spine. Well, if you do a cervical manipulation and you take that already weak ligament and rupture it, well, that could cause spinal cord injury or, at the very worst, death. So that's why it's absolutely contraindicated. And these conditions are also systemic. So somebody that has upper cervical spine instability may also have instability in other regions of the body. And so for that reason, manipulation is absolutely contraindicated. And along these lines, ligamentous rupture, contraindicated. Dislocation of a joint and even subluxation, contraindicated. The next absolute contraindication is an acute myelopathy, which you can also see with ligamentous instability in these connective tissue diseases and rheumatoid arthritis. Now, a myelopathy refers to compression on the spinal cord proper. But remember, the spinal cord terminates around L1 and L2, and inferiorly it becomes the cauda equina. And so this term myelopathy, we're also grouping in there cauda equina syndrome, where you have compression on the cauda equina. This would make manipulation absolutely contraindicated. Also, having had a recent surgery, acute soft tissue injuries, whether it's muscle, tendon, or ligaments, the presence of a tumor, an acute infection, systemic vascular diseases, and of course vertebral artery abnormalities. And these would be tested for by Haughton's test or the vertebrobasilar artery insufficiency test, or the VAT. And also being on anticoagulant therapy. An example of that being warfarin, which is also known as Coumadin. That one is extremely common. So these are some of the most common absolute contraindications that you would run across. Let's move on and discuss the relative contraindications. And for these, we're going to have to use our brain a little bit more. We're going to have to think. For absolute contraindications, well, if somebody has it, we're just not going to manipulate. Any kind of manipulation anywhere on the body. But here, we have to think a little bit. So if somebody has one of these relative contraindications, we're never going to use the techniques of the manipulation on that specific area with the contraindication. But other regions of the body might be acceptable to use the manipulation on. So let's look at those. The first one is having had an adverse reaction to a previous manipulation. Let's suppose that a patient previously had a lumbosacral manipulation and they really didn't like it. Okay? Well, you probably shouldn't do another lumbosacral manipulation, okay? But does that mean you couldn't do a thoracic manipulation? Maybe they would tolerate that better. Assuming you get patient consent, there's no reason that you can't do a thoracic manipulation if it's warranted, okay? Second one, disc herniation or prolapse, okay? Let's suppose somebody has an L3, L4 disc herniation, maybe even producing a radiculopathy into one of the legs. But let's suppose that same patient also comes in with a second diagnosis of neck pain with hypomobility. Well, the disc herniation's in the lumbar spine. So theoretically, I could be safe in doing a cervical manipulation to increase that cervical range of motion. Because if I'm doing a cervical manipulation, I'm not affecting anything in the lumbar spine. So it would be relatively contraindicated in the lumbar spine, but it would be okay to use in the cervical spine. Now, if I was doing a manipulation in the lower thoracic spine, I'd probably have to be a lot more careful there, and I probably wouldn't even do that because it is fairly close to that L3, L4 junction. Okay? Spondylolysis or spondylolisthesis. These are generally occurring in the lower lumbar spine, either between L5 and S1 or between L4 and L5. So once again, if you have a patient that also complains of neck pain, you could probably also get away with doing a cervical manipulation if it was warranted, because again, that's not going to affect the lower lumbar spine. The next relative contraindication is advanced degenerative joint disease or spondylosis. This is really just a fancy way of saying advanced arthritis. So let's suppose you have a patient with advanced spondylosis in the cervical spine. So that would mean that two of the cervical vertebrae are very close together because the disc in between them is degenerated, it's desiccated, and so oftentimes what you see in these patients is they have shortened necks because all the discs are very thin, and also they have limited range of motion. Extension, side bending tend to be most limited, and sometimes a little bit of rotation as well. Well, they have neck hypomobility, so I could do a cervical manipulation, right? No, because in this case, it's relatively contraindicated in the neck. But I could probably get away with doing a mid-thoracic manipulation, assuming that there's no advanced spondylosis in that region. Okay? So it would be relatively contraindicated in the neck, but not in the lumbar or thoracic spines. The next relative contraindication is vertigo, and the most common type of that you'll see is BPPV, benign paroxysmal positional vertigo. Now, this is only a relative contraindication for the neck. And why is that? Well, suppose you're going to do a rotational upglide or downglide manipulation on the neck. What does that thrust look like? Well, it's a rotation, a quick rotation in one direction. What is often an exacerbating factor for the dizziness that patients have with BPPV? It's quick rotation of the neck. And so because of that, we would not do a cervical manipulation on someone with vertigo. That doesn't mean you couldn't do a lumbar manipulation or a thoracic manipulation as long as it wasn't producing a huge amount of rotation or movement at the neck. But you would never do a rotational manipulation in that case at the neck. The last relative contraindication would be arterial calcification in a specific artery of the extremities. So let's suppose that a patient had calcification in the tibial artery of one leg. Tibial artery is, of course, below the knee. So one manipulation I would never use on that leg would be a tibiofibular manipulation. That's one of the less commonly used manipulations to increase proximal tibiofibular mobility. Would never use it on that leg. But let's say the other leg did not have calcification. I could certainly do the tibiofibular manipulation on that leg. I could do a thoracic manipulation. I could do a cervical manipulation. I might lean a little bit away from a lumbosacral manipulation. The bottom line is, wherever the calcification is, just don't do a manipulation anywhere near that. So hopefully this video gave you a good understanding of the absolute and relative contraindications to manipulation. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.